Okay, hi everyone. Thank you for joining us this nice cold Wednesday evening, and welcome to the first joint event between Newcastle and Birmingham Psychiatry Societies. We're super excited to have you. We're super excited to have such a brilliant panel of esteemed speakers to talk about intellectual disability, autism, and mental health. So we're going to start off with just a few minutes of housekeeping, where we can talk about who we are and what you can expect from the evening. So we're Newcastle University Psychiatry Society, which is the student-led society interested for careers in mental health. Our Facebook is at NUPsych. Our Instagram is Newcastle_psychiatry_society. And our Twitter is NCL PsychSoc. If you're a student at Newcastle University, you can sign up via NUPsych. Membership's only £5 for the year. So what we do is we host talks, events, workshops like this one that you're here now, all about mental health. Recently, we've been doing film clubs, and we had the president of the Royal College, Dr. Adrian James, come to speak to us a couple of weeks ago. And Lucy can talk a little bit more about Birmingham.
Hello everyone, thank you very much for coming this evening. So I'm Lucy, I'm the president of Birmingham PsychSoc. So similar to Newcastle PsychSoc, we organise a range of talks throughout the year, which are normally in person, but this year they're all on Zoom because of coronavirus. So we arrange a series of talks, and our society is completely free to join. And you can follow us on Facebook, Twitter and Instagram.
Okay, great. So just a couple of housekeeping bits for tonight. Just to let you know, the event's being recorded, so please don't say anything that you wouldn't want broadcast to the world on YouTube. Please keep yourself muted until the Q&A, where you can ask questions. The event's going to last around 2 hours, and yeah, if you have any questions in the meantime, feel free to post them in the chat while the speakers are speaking. Okay, great. So we can now move on to our first talk.
So I would first like to introduce Professor Ashok Roy. So Professor Roy is an honorary professor at the University of Warwick, and he's a consultant psychiatrist for people with intellectual disabilities at Coventry and Warwickshire Partnership Trust. Professor Roy is currently the Associate Medical Director for the Coventry and Warwickshire Trust, and was awarded an OBE for his work with people with learning disabilities. So thank you very much for coming, Professor Roy. I will just share your slides. Can everyone see those? Perfect. Oh.
Absolutely.
Goodness, sorry.
Okay, well, good evening, everybody, and welcome to this exciting evening. And thank you, Lucy and Ratnu, for inviting me to this event. So my topic is basically an introductory one, and I want to just share with you a small section of my life as a clinician. So the next slide will show you that we are talking about a week in the life of. So if you move to the next slide, Lucy, please, it's just to show that we'll describe an average week. Okay. So now we can move on to the next one. And the main areas of activity that I want to focus on are firstly, obviously, being a clinician, it's to do with clinical work, and I happen to work in both an inpatient and a community setting. So what that means is that in the community, I cover a catchment area, which happens to be the borough of Solihull in the West Midlands. And I provide psychiatric services for people with a learning disability who get referred to us by GPs and other agencies. So there I work as part of a multi-professional team with psychologists, nurses, speech and language therapists, occupational therapists and such like, and of course community nurses. And I have a small team of doctors working with me, trainees and staff grade doctors. So we work in the community, and for people who get extremely unwell and have extreme problems of behavior or mental health, they get admitted to a hospital where I work in. It's a small hospital. It's only got about 40 or 50 beds. And our own assessment and treatment unit is got 12 beds. And we take patients from the neighboring area, but we take patients from other parts of the country also. So we have patients from Manchester, Kent, Gloucestershire, etc., etc. So we get referrals from all over the place. And there also, I have a multidisciplinary team that I work with, consisting of the same professionals and looking after these the admissions 24 hours a day. And I'll talk a little bit about that later on. The next area of work is, if you just move it on, Lucy, please, is to do with education and training. And this is largely consisting of medical students like yourselves who get, I mean, we have 2 medical students posted this week to us, and we prepare a program for them. Different consultants prepare different types of programs. My main focus is that the students come and have a good time, do something exciting and have fun, because the idea is to explain, to show them that our work is actually hugely enjoyable, and they can learn and study stuff later, but they must basically come and see what exciting things we do. And then we have psychiatric trainees who are either training to be for their exams, or there are senior trainees who are specializing in ID psychiatry. So that's part of our core work. We also teach non-medical staff, such as nurses and other students that come, psychologists. And of course, not to forget that part of this involves our own continuing professional development, where we ourselves have to keep up with clinical and other areas of knowledge and demonstrate that we have are up to a certain standard, and that has to be accredited and verified and confirmed by the Royal College of Psychiatrists. So we have to do that all the time throughout our working life. The next area, which is a part of my role, is to do with leadership and management. And this is essentially to do with roles that one has locally in one's trust, regionally in the West Midlands, and nationally too, say in the Royal College or in other bodies like Health Education England or CQC, the Care Quality Commission. So psychiatrists can end up having roles in these bodies too. The other thing which is key to this is service improvement initiatives, audit, etc. So I asked my 2 students who came and had a look at this presentation and said, yes, it's all right. I asked them what they thought was the difference between management and leadership, because this is a common difficulty people have. A lot of trainee doctors think that management is essentially sort of boring meetings, lots of facts and figures, and they mix the 2 things up. So I explained that the difference is essentially that leadership is about doing the right thing. So basically finding or working out what is the right way for a service to develop, or the right way to see patients, or the right way to do things. That involves leadership, to vision that and sell it. And management is about doing things right. So once you decide you've got a plan of action, then you have to make sure that it is properly followed through, it's timely, it stays within budget, people have difficulties, they're supported. So that's the difference. And I think personally that for doctors, leadership comes more readily than management. And I think that's what they should focus on. And the fourth area, which is research, and that is something which you will cover in your in the talk which Professor Alexander has got just in a few minutes' time. So if you move to the next slide, I just want to tell you a little bit about the clinical scenarios. And this is all what happened in the last week. So I'm not going back in time. This is all I've done since in the last week. So there was we have in the inpatient service, our patients, because they are so severely ill, are quite complicated. And don't forget, they get referred from other services because they haven't responded to treatment in other services. And they have remained unwell and they get referred on. So we actually have to take some time to try and understand what the problem actually is. And we call those sessions formulation sessions, which are essentially making sense of people. So for example, a lady who got admitted about 3 or 4 weeks ago, I mean, she was at home with her parents unusually, because many of our patients often live in group homes and places like that. But she had been unwell for weeks and weeks or months actually, and become more and more suspicious of her parents, of her family, and of everybody around them, thinking that she was being hypnotized and there were forces that were controlling her. And the problem was that she also had diagnoses of learning disability naturally, because that's our specialty. And she had a diagnosis of attention deficit hyperactivity disorder. And they thought she also had autism. So the whole problem was trying to work out how to make sense of her. She believed that Michael Jackson's brother wanted to be her partner, and she was spending all her money selling her belongings to raise funds to visit him. And this whole thing began when she received an email saying that she'd won a prize. And this email had come from Nigeria. And she was then told that she won a prize. The prize was to go to America and meet Oprah Winfrey and Jermaine Jackson. And that's when her problems and that belief grew and grew and grew. And now she's come to the hospital without any insight whatsoever. She had refused treatment, refused any support, and had severely neglected herself. Her weight now is 155 kilograms. So she's really in a mess, and she's come in, and we are starting her on treatment. But that took some time to actually organize, because she didn't want to come in. We had to get secure transport. There was a big scene on the street where she hit her carer and hit other people. And anyway, it was quite a event. So that was an inpatient that is under our care, and we hope that she'll respond to treatment and go back to a new placement with much more support. The next patient is somebody who is been brought to us. He's a 50-year-old man with Down syndrome who has come with, basically his carers say that he's not doing stuff that he used to do before. He doesn't like going out. He doesn't even want to get dressed properly. He doesn't want to shave, look smart like he used to. He seems to be really out of sorts. And our problem, I mean, you may know that Down syndrome has got, is a syndrome where there is accelerated aging, and there is a number of possibilities that are, that could explain this picture. One of them could be an early onset dementia, which Down syndrome people are susceptible to. The others could be that he may be having a hypothyroidism, or he may be depressed, or he may be having all sorts of conditions that could explain, or he may be going deaf or having poor vision. We don't know, and our job is now to try and assess him, because the treatments that are available are very different. I must tell you, no talk is complete without describing a blunder I made some years ago. So there was this girl who came with a lovely Irish mother, and the girl had phenylketonuria. And she was quite a chirpy thing, and she would talk. And then her mother reported that she was actually changing. And she was like, she didn't like watching the telly anymore. And she was just walking around and as if she was lost. And I thought, this could be a depression. So I stuck her on antidepressant. And then they didn't come back for the next appointment. And they came back eventually about 2-3 months later. And I said, well, how are the antidepressants working? He said, I think they're doing okay, but actually she's much better after her cataract operation. So basically I had mistaken blindness for depression. And luckily some wise doctor found out the cataract and treated it. So one's got to be really quite careful about how one goes about assessing people. And the final patient I've got as an example for you is somebody who, so we have things called respite care services or short break services where people come for, say, a weekend or a week just to give their carers a rest. And one of the phone calls I had was this youngster who had come back with, who had come in, and he was getting slower and slower in getting dressed, in eating, and in talking, and he was just really hard. So breakfast, which would take normally 20 minutes or half an hour, would now take 1.5, 2 hours. And it was time for activity, he would take half an hour to get motivated. And this is getting worse and worse and worse. And then we looked at him, we found that he had developed a condition called catatonia, which fortunately responds very well to lorazepam, and so we started him on that. And these things were all people I saw in the last week or 10 days. So then what else did I do? Let's move to the next slide, Lucy. We went for let's take the quality improvement bit. So we did an audit on our medication practice. Now there is a national initiative which focuses on stopping over-medication in people with learning disability called STOMP, which is the acronym. And it showed that we were 21st in a cohort of 60 trusts in our quality of prescribing. So we had a long way to improve. And one of the key problems we found was that we didn't seem to evidence the fact that we were actually examining people for physical side effects of medication that we had prescribed. So how do we evidence this? So one of our trainees basically decided to modify our GP letter to cover the areas of that we had to demonstrate evidence for. And she presented this at a meeting this week. And there was a whole process of agreeing how does one launch this letter and who should it go to and how should we ensure that it is properly used and not ignored by the psychiatrists in the trust. So we are talking about how to fix a date, have a build up towards it, get the secretarial staff to understand it, get the letter put into our IT system so it becomes easy to produce, etc., etc. So the next thing that I did last week was I went to a conference where, incidentally, which was chaired by Professor Alexander himself, so he knows I'm telling the truth. We went to this conference where we went to launch a tool which was meant to improve the quality of management and also was a training tool for people with epilepsy. Now, epilepsy is prevalent in people with learning disability. More than a third have epilepsy, and often the epilepsy is quite hard to treat, presumably because there is most organic brain disease and damage, structural brain damage. But there's a lot of refractory epilepsy and hard to treat epilepsy and unusual and complex forms of epilepsy. Now, epilepsy presents an interesting dilemma for psychiatrists because traditionally, psychiatrists don't treat epilepsy. That is done by neurologists and pediatricians and people like that. But in learning disability psychiatry, because epilepsy is so common and is so intertwined with the psychiatric problem that they present with, that we now believe that psychiatrists in this field must have good basic knowledge of epilepsy management so they can make sense. Remember formulation, making sense, make sense of the people they see and understand the links between their epilepsy and their mental illness. And we know that the two things can often coexist and complicate each other. So that was what we did. We sat there and we listened to experts talking about their contribution to this tool. And the other thing was that it's all very well launching a tool which is very worthy, but we have to make sure that the right people are convinced that it should be implemented properly, and we can demonstrate the benefits to the people who it is meant to be used for. So that was last week. And then what else did we do? Yes, we were, I'm just giving an example of sort of things that probably would come under service leadership. So there is a high priority in learning disability services to avoid using inpatient beds if possible, because that is seen as being quite restrictive and often quite stagnating. And the idea is to try and treat as many people as possible in the community itself. And to that, we had to create a all-age patient journey so that they receive systematic treatment at the right time, at the right place, from the right people, right through their illness or their contact with the service. So we had to agree, how does one deploy the community team? You know, I mentioned to you earlier, I work in a community team. How does that team interact with the hospital team? Can the hospital team who has experience of difficult behavior go out to support community services to prevent people from coming in? What does that actually involve? We have an intensive support team. How does that intensive support team actually get involved in time to prevent people from going into hospital, or even those who are in hospital to hasten their discharge so that they can come out to the community without delay? So there was a meeting to try and agree what is called an operating model, which makes sure that people follow a certain process, which then ensures that there are no delays at each point of the patient journey. And this covers all the teams in the trust, because the journey is through all parts of the service. And then yes, and then I was telling you about this trainee supervision. So we had I had made this really, well, I would say that, wouldn't I? I made a really exciting program for them. And one of the sessions was what is called reflective practice. So this is where all the staff on the ward, or as many staff as possible on the ward, come to a room and talk about how they feel about their work, what patients are making them feel. Do they feel traumatized? Do they feel pressure? Do they feel successful, happy? So there's a kind of that's a facilitated session which allows people to communicate, and we find that really, really useful. So I'd actually asked the convener of that group whether he would allow the medical students to come and stand in, because people are talking about very deep personal, emotional issues. He said, yes, bring them in. So I went tootling into the room at 9 o'clock with 2 eager medical students in tow, and the room was empty. And then I realized that the meeting had been cancelled because of the lockdown. But I hadn't read the email which informed me of that. So I had to sit and tell them about management and leadership and about this patient. So basically rehearse the same talk that you're hearing now to them, which is why I'm feeling much more confident that you will understand what I'm saying. Okay. So I think that's basically it that I want to say, just to give you an idea of what an average week is for most of us who work in this service. So it's really exciting, it's really fun, it's very rewarding, and it's full of opportunities to do all sorts of exciting things that the world is the world is is your oyster there, and it's all open for business. So I hope you'll think about this specialty when you come to choose. Is that the slide, Lucy? I think that's probably it, isn't it? Yes. Well, thank you very much. I hope you found that faintly interesting and exciting. Thank you.
Brilliant. Thank you very much, Professor Roy. That was really, really interesting. And I can't believe that those were all patients who you've seen in the last week. Of such interesting cases. Brilliant. Thank you very much for sharing that with us. So if anyone has any questions for Professor Roy, we will be having a Q&A session at the end. So I'll now stop sharing screen and I will introduce Elliot Bernard-Cooper. If you'd like to share your slides, Elliot.
Sure thing.
Brilliant, thank you. So Elliot is a lived experience speaker who delivers his talks about his experiences with mental illness and autism spectrum disorder. And just this week, Elliot was awarded the Royal College of Psychiatrists Patient Contributor of the Year Award for 2020. So many congratulations, Elliot.
Thank you very much. All right, are we ready to go?
Perfect. Yeah, ready to go.
Okay, great. Right, so yeah, I'm Elliot. I'm going to be talking about lived experience with, as you can see, Asperger's syndrome, mental illness, and the overlap. Yeah, and for what it's worth, if anyone can point out to me in the Q&A session where I got this font from and where else it's used, you'll win, I don't know, brownie points or something. But please don't spend the entire talk thinking about, oh, where's that font from, rather than listening to the talk. Thank you. Anyway, is that going to advance? Please advance. Okay. So what are we dealing with? I'm just going to run through my diagnoses for the moment. So number one, obviously, is Asperger's syndrome, or autism spectrum disorder more broadly. I was diagnosed with that at age 10. And I suppose since I have Asperger's syndrome and I'm more on the more high functioning end of things, I don't necessarily have an intellectual disability as such, but the two, the two can often come hand in hand, especially at the lower functioning end of things. I also have a severe anxiety disorder, which I was diagnosed with alongside Asperger's. And next on, I have OCD, which is a sort of comorbidity with Asperger's. It wasn't something I was initially aware that I had, but over the years, it became something that I started to display more tendencies of, and my mum happens to be a consultant psychiatrist, so I talked to her and said, "Oh, do I have OCD?" And she said, "Well, as part of the Asperger's, yes." And I don't know. I think that, and I've talked to her, and that counts enough as having OCD on its own. So I say I have OCD, and given how many symptoms I display, I'm pretty comfortable saying that. Last but not least, I have depression. I was diagnosed with that in November 2014, which was just after I turned 18. It probably started in October. It was around the autumn half term that year that things probably started going that way for me. That was my A-level year. So now I'm going to talk about what each of them do, more broadly, and well, more broadly, but more specifically to me as well, and then later I'll get on to how they interact with each other. So starting off, I wanted to talk about Asperger's syndrome and what that does. So the first one, probably one of the most well-known one, is Asperger's syndrome. Asperger's syndrome provides difficulty in large or social situations. It can be tough to remain comfortable in those. They're not the sort of natural environment for someone with Asperger's or someone with autism more broadly. Shyness and anxiety. Before I was diagnosed, I remember I was always sort of just shy. I remember my parents would write into my new teacher every primary school year to say, "Oh, he's shy. Please be mindful of this." Before I had a diagnosis, and I felt quite awkward about it because being shy didn't feel like anything special. But yeah, Asperger's syndrome sort of puts a name to that. So I do feel quite a bit of shyness and anxiety around various situations. Obsessions and fixations. This is a rather important one. When I get an interest, I tend to focus in on it very specifically and start learning about all the minutiae of it. So, for example, if I played a specific video game as a kid, I'd play a lot of it in a short amount of time. And I move between things, and you might hear someone with autism talk about a special subject for them, and that relates to this. It's something that they are deeply, deeply passionate about and can just go off and talk about for ages. And I have a few of those. Does that make sense? Is there anything else I need to say about that? I think that makes sense. If you have any questions, then we'll have the question time. Rigidity and aversion to change. That's also an important one. Whether or not a change is good or bad, really, I've always tended to be not that keen on it. It's... Sorry about the pauses. I'm trying to collect my thoughts and figure everything out. Yeah, I've never been that fond of change. Even like changing between school years, that was part of why my parents would email, or not email, write a letter in at that point to my teachers. And like, it was part of why I was so worried about university, although we'll get into that not really panning out for me later. And when I get involved in new things, I always worry about what new stuff that's going to bring to the table I'll have to deal with. Or if I improve at something, I get worried about what the improvement might lead to in terms of how it's going to affect my life, like a hobby or whatever. And repetitive and ritualistic behavior. This is a pretty common one as well. I imagine you'll be familiar with it. So I have a tendency, and many autistic people have a tendency to repeat small motions or small, just little things that they would do quite a lot. So a fairly common one is when I'm a bit anxious, I might rock back and forth in my chair and rub my hands on my lap. I tend to do that when I'm nervous and trying to sort of blow off steam a little bit. An example my mum has used when giving talks is that you might see an autistic child, instead of playing with a toy car or something, they get fascinated with a small bit of it and they spin the wheel around on it. Something a bit like that. Next up is anxiety. So the word that's often been used, the word that was used by my consultant psychiatrist, as when I was a child, was trivial. I tend to feel anxious about really small things that don't really matter. I get nervous about making a choice of like, what I want to buy in a gift shop at the end of like a museum or something. I remember having that problem when I was a kid quite a bit. And like, well, I don't know which one will be the right choice. I don't know which little trinket will be the right choice. Not that you'd ever hold on to any of them for very long, really, as a kid. I also have difficulty starting or maintaining a presence in conversations. I find it very difficult to reach out to people and talk to them. It's a sort of overwhelming thing for me. So I don't tend to, like, a lot of school friends I haven't really spoken to a great deal since I left school, because trying to reach out on Facebook Messenger or whatever and say hello is just too nerve-wracking a thought. And similarly, when you're in the conversation, it can be difficult to not just get wrapped up in your own head and to keep talking. Physical effects. Oh yeah, when I'm anxious enough, I feel sick. I think that's probably true for a fair number of people, but it's worth mentioning here as part of anxiety as a disorder. So I feel sick. I will lose my appetite, which isn't great, because in January, for example, in January, I went on a flight to Florida before all the COVID stuff hit. It was a 9-hour flight, and I was anxious for the whole process, like going through the airport, going through customs, going through such and such and such. And then it only hit me as I was like picking up my bag from the other end in Florida. I'm actually really hungry. And then I felt like I was gonna like pass out or something because of how hungry I was and how little I had eaten on the 9-hour flight, because I was nervous the entire time, and I hadn't realized that I was just suppressing that. So yeah, I was more mindful to eat on the way back, even if I didn't necessarily feel like it. And difficulty leaving the house. So even before COVID, and particularly in touch with depression as well, but I'll get onto that later. It was tough for me to leave the house because for one thing, I hate public transport. I really, really dislike it. It's a big open thing. There's a lot of walking about and trying to figure out where you're going and how to get there, and trying to make the right timings for things and all the planning. I don't like it. I don't like it at all. But also just sort of going out there when you've got a space where you could, because I could be comfortable like in my room, and that's fine. So the thought of sort of leaving the comfort bubble is a bit difficult. OCD, rituals and compulsions. This is it sounds very similar to what I've said about Asperger's syndrome, but with OCD, it's a bit more involved. Like, for example, some rituals I have, I say good morning and good night to all the pets we have in the house in the same way. And if I mess it up, I have to start from the beginning, because I just do have to start from the beginning. It's just this overwhelming feeling that I've got to get it right. I will apologize to pets if I get in their way and they have to move out of my way. Not that they really care, or understand me, but I still feel the need to apologize. And sometimes I say goodnight to or apologize to like inanimate objects for the same reasons. Compulsions. One compulsion that I try to manage is that sometimes I lock my arms out. I don't know how well you can see that. Sometimes it feels like my joints aren't stretched out properly, and I lock my arms out to stretch them. And if I do that too much, because it never feels quite right, I end up causing pain in my elbows from overstretching my joints. So I try to keep that in check, since I've realised that was a thing that I started doing. Yeah, and next part, and this is an important part. You know, when you have OCD, that the compulsions don't really matter. You're well aware that it's not really going anywhere, that it's not really fruitful for anything, but you still feel the need to do these things, or say these things, or perform these actions. Often that's a cause of significant distress, at least for me. Like, it bothers me that it takes up all these little chunks of time that add up to do all these little rituals that I have. It's no fun, really. Rumination and obsessional thinking. This is quite a big deal for me, especially in when I was in my teens, and perhaps in some more recent years as well. I have a tendency to, if I get worried about something, think of it from every possible angle and not be able to stop thinking about it. So it will take over all of my headspace, and I'll be completely honed in on it. And it's very stressful and difficult. Yeah, rumination is the term that my mum has described it as. I think that's also a clinical term. But yeah, basically I find it very difficult to not think about something if it's bothering me. And I've got a bit better at it since my teens. It was particularly bad in my mid-teens. But yeah, it remains a thing that's there for me. And intrusive thoughts, that's the other one. This goes pretty well hand in hand with rumination and obsessional thinking. But I'll try and think of an example. Have you ever I don't know, it's a little bit morbid, but have you ever, like, gone up to, like, a bridge or a cliff, or up some sort of high space, and then suddenly a bit of the brain somewhere deep back in your head just goes, "What have I jumped off?" Like, and it's not because you're suicidal. It's not out of that. It's just this weird sort of random pop-up thought that comes into your head. That's what an intrusive thought is like. But it's not necessarily little moment-to-moment things like that. Sometimes intrusive thoughts for me are often more particular worries that that sort of remain, and sometimes they come back to you and I start thinking about them again. Depression, lethargy, so I feel tired a lot. That sort of speaks for itself, really, doesn't it? Lack of motivation, again, sort of speaks for itself. I have a very difficult time feeling any sort of drive for to do stuff, even stuff I'm interested in. It's depression, so I have a pervasive low mood or lack of strong mood either way. I tend not to feel, a lot of the time, I tend not to feel much, or if I am feeling a strong mood, it tends not to be a nice one. And again, difficulty leaving the house, because I don't really want to. Like, I'm tired, I don't have any motivation. Like, why should I? I can stay in my room and be comfortable and play a video game or something. So that's what they do. But in reality, if you'll advance, it's a little bit more like that. So I've tried to explain these all individually, but really in my head, that's not how it works. That's not how it ever works. It's all in there together, and it's all mixing up, you know? So I want to talk about how Aspergers in particular interacts with comorbidities. So Aspergers and anxiety. I get really anxious because of these two things together. Because you often feel nervousness as part of Aspergers anyway, but I feel very nervous because I have this anxiety next to it. Again, difficulty with social interaction, events, new people, travel, because you're nervous about it anyway, but then you've got the anxiety on top of it, and you've got the awkwardness of trying to suss it out with Asperger's, and then you worry about, oh, am I going to get this right? Am I going to say the wrong thing? Am I going to muck it up? I often feel anxious before or during anything that feels important, and that's not limited to people on the autistic spectrum, but it's a sort of bodily anxiety. You feel shaky. You feel like it gets into your head a little bit as well. That's probably part of the reason why sometimes I just pause and I just have to think about what I'm saying as well, because I need to collect my head and figure out where I'm going with things because I'm anxious. And shut down, especially in social situations, which I like to explain with something I call the protein analogy, which I put with a nice shiny reflection below it because I'm very pleased with it and I think it's very clever. The protein analogy, I assume at least some of you are aware with how the body consumes fat for energy reserves, and once it runs out of those energy reserves, it starts consuming muscle and protein, and this isn't good for the body. And I feel like my brain works in a fairly similar way. So once I run out of the energy I've got stored up for social situations, I start to consume the rest of my headspace and I retreat into myself and become way less talkative, and it becomes difficult to remain involved in a conversation, for example. And the rumination that I have, that's also very strong. I get very, very worried about it, to the point where it's like fear sometimes. Asperger's and OCD, not entirely sure how much time I've got left, but I'm trying to go through it at a decent pace. Repetitive mannerisms. Yeah, sometimes I have a repetitive mannerism that will start as part of Asperger's, so it'll just be something I do as part of just a little repetitive motion or thought or something. And then the OCD side of me will sort of notice it and will take it further and sort of codify it into a stronger ritual, which I become more conscious of, and then have to figure out how to break sometimes. Greatly increased rumination. Yeah. So the rumination, like I said, I tend to attack the thoughts from all angles. And Asperger's and OCD, I'm never really satisfied with a thought that's in my head or with a rumination specifically, until I know, until I can figure it out from every side. So if I think, oh well, this solves it, but then I think, oh but wait, what about this? What if this could be a problem with it? So you're never quite free until you think you've figured it all out. Often I have to go and talk to someone else about it instead, because other people are better at thinking more stably than I am about these kinds of things. Yeah, so and feeding back into that, I tend to, if I have an intrusive thought, often it gets hard to just sort of go, like, that's a weird thought, like, and shoo it away, kick it away. Sometimes I'll think, but what if that says more about me than I think it does? And then I start thinking about it, and then I don't stop thinking about it for a while, and I start ruminating about it. Perfectionism as well. I've always been a fairly highly strung perfectionist, to a fault sometimes, and I've learned to deal with that. It was very bad as a child. Yeah. You can advance. You're going to do this for me. There we go. Asperger's and depression. Executive dysfunction. I think you might be familiar with that phrase. I'm not sure how clinical it is, but it's something I've heard tossed around. So I've also heard it used related to ADHD. But basically the idea is you can spend all your time whittling away, like watching YouTube or something, or doing something that doesn't really build on anything. But when it comes to the important stuff, like homework in school or whatever, it becomes very difficult to maintain any sort of interest or focus. So basically, things that I'm interested in, or things that are not a big deal, I guess, executively or administratively, are way easier to sort of just think about and process and just stick to, rather than the things that actually have a little more riding on them. I also have difficulty. Yeah, well, there you go. I have difficulty focusing on things that I'm not necessarily interested in as well. And this isn't necessarily just a comorbidities thing either. I'm sure a lot of people feel this way, but it's quite strong for me. That if I'm interested in reading about something on Wikipedia or something, I can read about it for ages. But if I had to do an essay at school or something, it's very difficult to sort of just hunker down and just go, right, I'm going to do this, because my mind will just spiral off and drift off into different places. Sleep schedule trouble. This is mostly depression, but Aspergers, as I've written, makes me less inclined to fix it and more inclined to persist. I am a fairly notorious night owl at the moment, and I never really used to be, but because of depression, I ended up staying up later and later in the past few years, and sort of as my schedule became less regimented, that became easier to do after school. So I end up staying up pretty late into the small hours of the morning, quite a lot. I also have difficulty trying to learn and practice new things. So perfectionism and lack of motivation, it's a bit of it's between them. So let me think. So if I wanted to learn like a new instrument, say I wanted to learn the guitar, well, it's like you've got to start off being not very good at the guitar, and that doesn't sound very fun. So it's a bit frustrating, and then I don't have the motivation to go through all the bits where you're just sort of plonking one string at a time. Yeah, I think that'll do for that. Okay, for some reason it keeps not advancing by one. Anyway, they interact with each other too. It's not just Asperger's and thing, it's also thing versus thing. So anxiety and OCD make my rumination even more intense as well. Anxiety and depression, I have difficulty reaching out to speak to people. OCD and depression, I end up feeling bad and low and upset about my rituals because I don't like them. And that's just one example for each of them. That's not exhaustive as a list, but I figured it's important to mention. And please do this for me. Last but not least, it seems to have real trouble moving through slides. I don't know why. The effects of COVID. I figured this is important to mention, just briefly. So I felt really low during the first lockdown. Like that, I had built up a few good habits before then, and then it just fell apart. So I had managed to fix my sleep schedule a bit, and it just dissolved again. I felt bad at the announcement of the second one as well a few weeks ago. Good habits, yeah, my good habits were swept away by me just feeling bad and thinking, well, what's the point, you know? So I sort of lost the habits I managed to build up in the months prior. Sleep schedule, yeah, night owl territory is how I would describe it. I stay up really late. I also wake up really late. It's not fantastic. And I will work on fixing that. And I've done it before more than once, and I'll do it again. But COVID didn't help. So I just ended up just losing all sorts of losing the ability to stick to what I had going. But I suppose the last point is that my life, due to depression and anxiety and all this, I've sort of spent a lot of time in my house anyway, and I don't want to diminish the importance of COVID and of lockdown. But I said to my mum a few months ago, like, it sort of feels like I've been in lockdown for the past 5 years because I've been in lockdown because of my own head, of my own brain. makes it so that I haven't really been able to go outside that much. I haven't really been able to interact with people that much. I have a bit, obviously more than I can now because of the virus, but not as much as I would like. I've felt sort of trapped by those aspects of my head for quite a long time, and it's getting better, but you know, it remains. And this list is also not exhaustive. That's important to note. Thanks for listening. Yeah, that'll be me. I'm sorry I overran by a bit. I think I did, but I hope that helps you. If you've got any questions, again, we can field them at the end. If you want to tell me what you think the font is, but I hope you did pay attention. Yeah, thank you very much for listening, and I hope it helps, and thank you for inviting me to this.
Brilliant. Thank you so much, Elliot. That was absolutely brilliant. The way that you talk about your experiences so articulately and eloquently is absolutely amazing. Thank you so much for that. So I would now like to introduce Professor Reggie Alexander, and I think that Ratnev is sharing Professor Alexander's slides for him. So Professor Alexander is, sorry, 1 minute, just a technical. Sorry, there we go. So Professor Alexander is a visiting professor at the University of Hertfordshire, and he is a consultant psychiatrist in the Hertfordshire Partnership Foundation Trust. Professor Alexander is an Associate Dean of the Royal College of Psychiatrists, and he's a convener for Radiant, which is a research in developmental neuropsychiatry. So thank you very much for coming, Professor Alexander. Over to you.
Thank you. Thank you, Lucy. Thank you for inviting me, and it's good to be with all of you and in such good company this evening. When I got this invitation from Ratnu a few months ago now, one of the things he told me was, oh, it would be good if you come along and tell others what it is that you actually do. And it's one of those strangely perceptive statements. What is it that any of us actually do? And for someone like me who hadn't prepared for an interview or hadn't prepared a proper CV for a little while, it was a good start to put down a few things on paper. The next slide. So this is what I actually do. So my full-time job is as an NHS consultant. I look after about 16 inpatients and about 50 outpatients in an intensive community support team. About half of each of those numbers are the so-called forensic patients, i.e. they are patients who have got into some sort of trouble with the law, and the rest are, shall we call them, non-forensic, whose distress is as real. Along with that, I do some of the other roles that Lucy mentioned. I have an honorary position with the University of Hertfordshire, and I contribute to two national bodies. So I look after advanced learning and conferences for the Royal College of Psychiatrists, and I contribute to the Royal Society of Medicine's Intellectual Disability Forum, which had the epilepsy conference that Ashok was talking about earlier. In my editorial responsibilities, something that I'm a little bit vain about, really. I edited with the late Sam Bhaumik the first Oxford textbook of the psychiatry of intellectual disability, and the British Journal of Psychiatry Open. But perhaps the role that gives me most satisfaction, Ratnu, the next transformation, is the role as editor of a small East Anglian community magazine called Village Voice, which has a print circulation of about 4,000. It is not a primarily psychiatric magazine at all, but it has a focus on health policy and also the political decisions that underpin those practice decisions. And finally, as Lucy mentioned, I contribute to research in developmental neuropsychiatry, which is a network of about 20 NHS trusts and about 50 experts by experience, people like Elliot and family members who contribute to the research discourse. The reason why I say that is you can do a full-time job in the psychiatry of learning disability and still have a rather interesting portfolio to run along with that. And if I can do it, anyone in this audience can do it too. So that brings me to the topic of the psychiatry of intellectual disability, and allow me to start with a comment about psychiatry in general, which appears pertinent for a PsychSoc meeting. The next slide, Retno. So Joanna Cannon is one of my favorite new breed of authors, and some of you may know her. She had the most unlikeliest of origins as a medical student. She graduated from Leicester Medical School, actually in more or less the same batch as Sam Tromans, who will talk later, and then went on to become a best-selling author of at least 2 novels which appeared on the Times bestseller list. And that quote is from her memoir, Breaking and Mending, where she says that if medicine is conceived as a book of stories, then psychiatry holds the wisest chapters. And if you think of the psychiatry of people with developmental disorder, in the wisest chapter that is psychiatry, that surely has some of the most poignant passages, because you are dealing with a group of people, a population who are marginalized, who lack not just equity of access to healthcare, but also a lack of equity of treatment outcomes. And many of you are young enough to remember your medical school interview days. And the one question that you are guaranteed to be asked is, why do you want to become a doctor? And your stories will vary from wanting to help people, wanting to make a difference, being interested in people. And psychiatry of learning disability, or psychiatry of developmental disorders, is a field which brings home to you the true meaning of some of your rehearsed medical school interview answers. Because you, and here I am paraphrasing Joanna, you truly realize that you save lives not just on the hard floors of emergency rooms, but also in the quiet corners of wards and the quiet conversations in community teams. So I want to start with what I'm calling 5 lessons for medical students about the psychiatry of intellectual disability. The next slide, Ratnu. And the next slide. Point 1, you are going to deal with a population which has excessive physical and psychiatric morbidity and, crucially, mortality. So the average male with an intellectual disability dies about 10 to 13 years before the average age of death of someone in the general population. For females, the premature mortality is another 5 years earlier. So substantially increased mortality, which is not just related to the genetics of the condition, but also accessibility of healthcare. The second point, you will see unique neuropsychiatric presentations. And Ashok talked about epilepsy a little while earlier. You can spend a whole lifetime in adult general psychiatry. You can pass exams reading about periictal psychosis and probably see 1 or 2 patients with that condition in your entire psychiatric career. In about the first 2 months of your practice in the psychiatry of intellectual disability, you would see that number. So, and that I'm using as one prototype, so unique neuropsychiatric presentations. Point number 3, the presentation of mental illness. So the presence of cognitive disadvantage, whether it is an intellectual disability or whether it is a developmental disorder like autism or Asperger's syndrome, affects not just the prevalence of the disorder, but also the presentation, the clinical presentation of the disorder. It affects the treatments you give and the treatment outcomes you get. And Elliot has brought home that point with a certain eloquence and clarity that I wish I could match. Point 4, very, very crucial, and I think Ashok touched on this earlier, the importance of communication. You know, if the essence of psychiatry is learning, that it is not just learning to talk, but to actually listen, you learn it properly in this subspecialty, because you learn the power of observation, you learn the subtleties of communication. And regardless of whether you become a specialist in this field or not, it makes you a better doctor. Point 5. This is slightly technical, and probably this is the forensic side of me coming in. You learn about the concepts of mental capacity and what one means by whether somebody has capacity or not. Once you get into your final year and your FY1 years, the two commonest fallacies are, the first one is a question, does this person have capacity? There is no capacitometer. Capacity is related to the decision that has to be made. You learn that with a certain vehemence in this specialty. The second fallacy is, does this person have capacity? Let us ask the psychiatrist that question. That question is not for the psychiatrist, but for the treating physician or the treating surgeon. And you learn the theory behind all this when you work in this specialty. Let's move on to the next slide. So I'm going to keep to this theme of 5 or 6 points. So this is broadly about research in the psychiatry of developmental disorders. The first point, I'm really not being a recruiting sergeant for the specialty. I see Ken Courtney in the audience. He's probably going to shoot me for saying this. I genuinely say that psychiatry is not just for those who are interested in a career in psychiatry. This field and psychiatry in general is for anyone who is interested in being an empathic, caring, and educated doctor. And education is not just about passing exams or getting a distinction in your viva. Education is as much about empathy and learning to communicate effectively. That really should be the starting point for setting out on the research journey. And it is never too early to start. Some of the most effective papers that we have published in the British Journal of Psychiatry have had medical students as co-authors. And quite often, a very good starting point is to start with case reports. You start with interesting case reports. Ashok gave you some examples, but see beyond the caseness of the case report. Do a literature review around that. Examine about service delivery issues and write it up. That is really my point 3. If you spend time researching things or learning about things, even if it is to present at a grand rounds in your hospital, write it up. Write it up and subject it to the scrutiny of peer review, because the scrutiny of peer review, the approval of peers, is the highest form of approval that you get in this field. The biggest bottleneck is between presentations and writing up, or between writing up and the first rejection. So the average person goes through 3-4 rejections before something is accepted. So keep writing it up and have the patience to make changes. Point 4. Again, I'm told off for this. If you are treating groups of patients, learn to count and count meticulously. So learn from the surgeons who keep logbooks of the number of procedures they do, their outcomes for that, their complication rates, and so on. Sometimes when we are caught up in the empathy and all the communication skills that I mentioned before, we sometimes lose the cold-blooded method in meticulously recording our outcomes. So if during the course of a posting you do 6 autism assessments, you treat 16 people with autism and comorbidities, keep an anonymous record of that, count it meticulously, and try converting your logbooks into informed case series. Number 5. I think Elliot touched on this, but in the course of describing his anxiety and his AD symptoms, this is Voltaire's quote, "The perfect is the enemy of the good." In the process of writing up, other people call it the nirvana fallacy, do not aim for perfection, but do not be put off even if you do not achieve perfection in your written material. The good is good enough, subjected to the scrutiny of peer review, and who knows, it might get published. And in doing all this, that is my final point, have someone to guide you. It could be a senior colleague, could be a registrar or a senior house officer or a consultant. Preferably, let it be someone who doesn't take themselves too seriously or who doesn't sort of overload you with stories of how busy their lives are. Because none of us are that busy, but do find the right mentor and try to move forwards in creating the research portfolio. The next few slides, I'm going to give you an idea of what is available out there. So this is the website of the Royal College of Psychiatrists, the Intellectual Disability Faculty, which gives some of the main research centers in the country. And as you can see, Newcastle features quite prominently. There is the website, the email address of Mark Woodbury-Smith, who's based there, but also form lateral links. So you needn't necessarily link up only with psychiatrists in intellectual disability. So if I use Newcastle as a typical example, the neurology department there, people like Rach Thomas, a consultant neurologist, works very closely with intellectual disability psychiatrists and deals with the interface between physical and mental health for this population. Go out and make those links. And these are people who are easily approachable. If you go on to the next slide. So going to universities is one. The other thing is making links with research networks. And there is Radian, which I mentioned, that is the website address. It is a fairly a network of fairly unassuming people who are quite approachable. So do feel free to drop us an email and we can offer help. And we are always looking for people, particularly medical students and junior doctors, who can contribute to projects and get a tangible reward for that, reward in terms of presentations or publications, not monetary. Next slide. If you think a jump to a academic publication is a jump too much, in terms of your career development, writing health education columns for the lay press, it can be equally productive. So the Village Voice that I spoke about before has featured a number of columns from multiple authors, including medical students. So do feel free to contact us about that. And they do rather exotic things, including the next transition, Retno, and the next transition. Yeah, so they do a variety of things, including interfaces with people who make political policy for us, and you can contribute to that. And if you're thinking purely in terms of your career, these publications too can be helpful. Next slide. You can contribute, you can try and compete for prizes and bursaries. I'm showing two examples from the Royal College of Psychiatrists Intellectual Disability Faculty. There is the Jack Piershaw Prize for Research Posters. There is the John Bicknell Essay Prize, open every year. Do visit the website and consider entering. So these needn't necessarily be research projects. It can be a considered essay on something that you write. Next transition, the Royal Society of Medicine. I know budgets are tight, but do seriously consider spending £90 for a 3-year subscription, student subscription, which opens a range of essay competitions and student prizes and so on. And the range of opportunities is limitless. And you really don't need to do top-notch research projects for that. You could do a non-systematic review and quite often get prizes and help your career in that way. Next slide. And of course, my favorite, the International Congress of the Royal College of Psychiatrists, is usually there in June every year. COVID put paid to that in 2020, but in 2021, we return with a virtual platform, which I'm told is slightly better than what we are used to. Do consider the abstract submission deadline for poster presentations has not yet passed, and you could work with your colleagues in your firm to put in submissions for that. And there are special categories for medical students. Next slide. The next couple of slides are only for your information. You can take it away, because I thought it would be amiss if I'm called to give a lecture on research and I don't mention the research priorities at all. So the next two slides list the research priorities in this area as set out by NICE and other prominent bodies. So there are the research focuses on interventions as well as epidemiology. Next slide. And the more exotic ends of the specialty, from genomic medicine to cutting edge physical healthcare development. Next slide. I've put my email and the Twitter handle there. Please feel free to contact me. I generally tend to reply. The Twitter messaging, a particularly effective way of communication. I'm very grateful for your attention, and thank you very much once again.
Thank you very much, Professor Alexander. That was really, really interesting and very inspiring. Thank you. So I would now like to introduce Dr. Levick. So Dr. Levick is the higher trainee co-rep for the Faculty of Intellectual Disability. And Dr. Levick is also the newsletter editor for the faculty newsletter. So if you'd like to share your slides. Okay, can you see that full screen?
Great stuff, yes.
Brilliant, thank you so much.
Thank you everyone for bearing with me there. Of course, we tried it before it all started and worked beautifully, and anyway, here we are. So yeah, my name is Kathleen Levick. I'm a ST5 psychiatrist specialising in intellectual disability, and I work in South East London. Lucy mentioned that I have been the co-rep for the Royal College Faculty of ID. I'm actually just finished and handed over a number of days ago. Yeah, but it's been a wonderful experience to have been doing that. So we're going to try something. I wonder if you can move forward to the next slide. That's brilliant. And click once more, please. That's great. Okay, so we're going to see how this works. So usually I would do this as quite an interactive session because I would have a group full of people in front of me. Now, obviously it's going to be strange on Zoom because I won't be able to see you. So I'm just going to have to trust that you're going to do this along with me. One of the key things in intellectual disability psychiatry is communication skills. And one method of communication that a lot of our patients either use regularly or at least are familiar with is Makaton. And I don't know whether people have are familiar with Makaton. See this gentleman in the bottom left of the screen there. That's do you know his name at all? Anyway, so he is a children's TV presenter, and he uses Makaton all the way through his TV shows, and he so a lot of small children will be familiar with these signs as well, but a lot of people with LD will be using these either in college or in residential areas, residential homes. The idea is that it's an aid to communication, so it's a supplement. It gives an extra way for someone to know what you're saying. So you speak at the same time as signing, so they have two clues as to what's going on. It means you tend to slow down what you say, and you don't supplement every word in the same way as you do in British Sign Language, but just the key words. So let's try. I'm going to trust that you're going to try along with me, and we'll try these again at the end, okay? So for the first one is hello. So you go, hello. So usually what you're doing, you're always using one hand, which is your main hand. Thank you, Lucy, for a bit of feedback there. You're using your main hand. So if you're right-handed, it'll be your right hand. And most often you're just using this one. Occasionally you'll use the second hand as a base, but mostly it's just the one hand, okay? So hello. Okay, and you say it at the same time as you do the sign. And then you say goodbye. And a lot of them, as you can see, are very natural, what you would do anyway, although sometimes you can get confused and go hello, and then people wonder because you're doing the wrong sign, but mostly people will follow along and it will feel natural and they'll understand because you're saying it at the same time, okay? So yes, Now you think of a nodding head when you say yes, and that's what you're doing with your hand. That's yes. Okay. Exactly. Very good. And so no, no. So sweep across your body, no. Okay. And again, the facial expression really helps because it's another clue as to what you're saying. So good, good. Okay, and then bad can be difficult to remember, but if you think of the opposite of good, so if that's good, the opposite is bad. So bad is your little finger. Okay, bad. Now, please, the person who taught me this told me it used to be, so you say tie to the bra, so it goes down to the middle of your chest. Sorry, thank you goes down to the middle of your chest, whereas please to the knees, and it goes further down. Okay, so the long one is please down to your knees, and tie to the bra, very short down to your chest. Thank you. And where, and again, it's sort of familiar. Where, you use both hands, where. And then the last one, finished, finished. And these can be really useful. You imagine that someone is getting tired of you chatting on in clinic, and you're like, it's okay, you know, you've done very well, it's good, and we are finished, so goodbye, and they can go. Okay, very good. All right, so let's move on now that we've done a bit of that. I'm aware that, sorry, I was about to press my forward button. Lucy, would you mind moving the slide on for me? Thank you.
Of course.
I'm aware that there's some stuff that we've spoken about already, which I think, you know, various people have touched on. So we'll just zip through this. So intellectual disability, we often still call it learning disability in the UK. And the reason we've tried to move towards intellectual disability rather than learning disability is to really contrast with learning difficulties. And what we're talking about there is specific learning difficulties, things like dyslexia, dyscalculia, dyspraxia, rather than intellectual disability, which is a lifelong condition. So it should be present from childhood, and it means that people have a lower cognitive level than general population. We're talking about 1 to 2% of the adult population in the UK, and you can just see that little figure there. That's a figure from MenCap. So even if you don't specialise in intellectual disability, chances of coming across someone with an intellectual disability in your general working life is probably quite high. And actually, you know, you may have come across some already. You may not even know whether you have, because it's not always obvious from the outside. You may be related to someone. You may know someone in family or friends. So yeah, there's a real diverse range in the patients as well. You have borderline to mild LD, and these people might have, you know, might have jobs and live independently and have difficulty with certain things and need just a small amount of support, through to people with really severe or profound intellectual disabilities who might never live independently, might need 2 or 3 to 1 care and hands-on care for every aspect of life, from washing themselves, eating and drinking, everything. So there's a real range in the patients that we see. There are many, many different causes of this. So it can be genetic causes, things like Down syndrome, Williams syndrome, Rett syndrome. There can be maternal infections during pregnancy, environmental causes. So, you know, again, during pregnancy, for example, there can be sort of perinatal causes. So things like cerebral palsy due to a traumatic birth, and various other ones. So other things like neurodevelopmental disorders like autism spectrum disorder, which we've heard a bit about from Elliot. Autism spectrum disorder can be quite a wide-ranging thing as well. As Elliot mentioned, not everyone has an intellectual disability, but quite a large proportion of people with that diagnosis do, and so they come under our auspices. And ADHD as well, obviously. So I'm moving forward, thanks. Okay, so just briefly, it's a bit of a busy slide there, but I'm going to say this a few times as well. All psychiatry is here. So every aspect of psychiatry shows up in intellectual disability psychiatry, okay? So as you can see there, 25 to 40% of people with intellectual disabilities will suffer with some sort of mental health problem or dementia. So it's far higher than in the general population. Similarly, in children and adolescents, those with learning disabilities, about 36% of them will have a mental health disorder versus about 8% of children without an intellectual disability. So really, this is common in this patient population, and also it shows a little bit actually. If, you know, if you're interested in child and adolescent, or if you're interested in schizophrenia or dementia, all of this is there. It's there in intellectual disability psychiatry. Challenging behaviour, something's been mentioned before, and that can be a large part of what we look at as well. So next slide, thanks Lucy. So talking about, I suppose, challenges in intellectual disability psychiatry, we've touched on it already a little bit. So communication can be challenging because you might be dealing with someone who is non-verbal or has less ability verbally to explain to you what it is they're experiencing. And that can be difficult, but it can be really rewarding as well, actually, because it really makes you think holistically about how you're communicating with that person. And certain things like Makaton can help with that. People use visual aids, so they can use pictures to show what they need at that time of day, or with how they're feeling, you know, to do with their emotions, for example. Other challenges, you know, are capacity issues, for example. And again, I think someone touched on this, but, you know, we deal a lot with Mental Capacity Act and Mental Health Act. So again, that can be really, really interesting. There's a concept called diagnostic overshadowing, which is something that I think we should all look out for all over psychiatry, but most especially in intellectual disability psychiatry. So this concept means that one condition means that other conditions may be overlooked. And I think, again, I can't remember whose example it was, speaking about a patient who they thought that she was depressed, and it turned out she had cataracts and that had been the problem for her. That's a sort of an example of it. So one starts to think that it's due to their mental health or it's due to their intellectual disability, and actually you're missing something, another diagnosis which is there. And it's something that happens to all of us. It's something, just as the previous presenter pointed out, it's something to keep on the watch for. And it's something that we can help our colleagues with, people who are less familiar with people with intellectual disabilities, because it's something that we come across more often. So it's something that we can really help other people to spot. And, you know, it's a really good thing to keep at the top of your mind. There are certain preconceived ideas about this patient group. So I've heard people say, well, they don't get better. People with diabetes don't get better, but you can treat the diabetes properly and make sure that they live a good life and that certain bad consequences of that illness don't come about. And that's something that we really have to be doing for this patient group. So we should be advocating for them because it's a group of people who have less of a voice, really. Sometimes they're less able to advocate for themselves. Not always. Sometimes, you know, there are some very well-known patient advocates, but, you know, sometimes they are not able to. And just in society in general, this is a group which is overlooked. We don't see them very often. And, you know, that's something that we can help with as their doctors. So next slide, thanks. So yeah, the interesting aspects as well, I think we've covered a lot of these. So the cases can be really complex. So we're not even just looking at mental health. Quite often we're looking at physical health as well. A lot of, say, the genetic syndromes will have a lot of physical health comorbidities. And just in general, this patient caseload will have a much higher physical health burden. And actually, again, we've spoken about that before, that in fact, the advocacy is important to try and prevent health inequalities, because actually one really notices in the average lifespan of this group of patients that it's lower than the general population and lower still than people who have just mental health disorders. And it's not all down to the fact of the physical aspects of the disorders they have, but actually health inequality. And that's part of all of our jobs, to make sure that we're doing the reasonable adjustments that mean that these people can access healthcare as they should be able to do. You're working with a big team of people. It's one of the really truly psychobiosocial is the proper way, isn't it? Aspects of medicine at the moment, where you really have to look holistically at the person in their social environment, you know, in their health environment, and see every part of the person to be able to treat them properly. So it's really fascinating. Next slide, thanks, Lucy. So again, I'm coming back to this. All of psychiatry is here. Anything that you're interested in doing, it's here. And again, I think it's been touched on before, but if you want to do child and adolescent, you can do it. If you'd like to specialize in forensic, that's a really big area in ID psychiatry. You know, neurodevelopmental conditions, genetics, epilepsy, again, it's been touched on. There's a lot of areas you can get into research. And at the moment, in terms of dual training, that is available in CAMS and intellectual disability, but not in others. Forensic is on its way, but it takes some time to get these things processed through the GMC. But because of that also, it means that you can direct your training the way you want it to go, really. So for example, I have quite an interest in forensics, so during my special interest sessions I have spent a year going to Wandsworth Prison doing ADHD assessments on the inmates there. I have spent a year going and doing court liaison and diversion for people specifically with intellectual disabilities in Camberwell Magistrates Court, and there is a paper in the pipeline, and as someone mentioned, you have to be dogged at keeping on to make sure that stuff gets published. Yeah, so there's a lot of stuff that you can do to mould your training the way you want it to go. Next slide, please, Lucy. In terms of extracurricular stuff, so there's a lot to say here, and I'm going to do a bit of shameless self-promotion. It's a small group of people, the trainees, so it's a fairly small specialty in some ways. Now, the really lovely thing about that is that you get to know all of your colleagues, and that means across the country. And it also means that there's a lot of opportunities. And for example, if you'd asked me 5 or 10 years ago, what might I be doing, I would never in my wildest dreams have said I've been the national rep for the Royal College for my higher trainees nationally. I never would have thought I would have dared do such a thing. But having come into ID Psychiatry, I feel like I found my place. I love the specialty. I love my colleagues. I love the patient group. I really enjoy doing this kind of thing now, which again, I never would have thought would have been me at all. Because of loving it so much, I ended up thinking, why not? I'll apply for the rep post, and I got it. And through that, I ended up doing the Choose Psychiatry campaign last year. And there's a few videos and interviews about that on, in fact, I think I've got some links to them a bit later. There's a podcast that I did just a month ago, which was to do with that. Through this, I've also become the editor of the newsletter. There's the cover there. And again, I would really encourage any of you, and I think again, people have said this, do write something, you know, write about your experience that when you've come across people. There are prizes and bursaries, there's newsletter. We'd love to have you send things into me there. The work-life balance is really great as well in this specialty compared to a lot of others. And I think, yeah, just general enjoyment of one's work is high. So next slide, please. To do a very quick whistle-stop tour about communication tips. I think this is really, really key. Whether or not you end up in ID Psychiatry, this is going to help you with any patients you come across, and especially with this group of patients. Take your time. Give this person time to speak, because sometimes actually if language or something is difficult and if their processing speed is difficult, they're going to need extra time. And you ask a question, you think, oh, they're not answering, and you move on to the next thing. And they're still trying to make sure they've understood what you've said, maybe trying to formulate an answer for you. So give yourself an extra time for the whole thing, and give yourself an extra time for each question as well. Leave enough time that a person can answer for you. Remove distractions as much as possible, because sometimes things like smells or bright lights or sounds can really distract and mean that that person is not able to concentrate on what you are saying to them. So if you can be in a room with fewer distractions, I know that's difficult sometimes, but as far as possible, that can be really, really helpful. Keeping it simple is really helpful. Don't ask questions with multiple parts. Make sure that you're using clear, simple phrases, concrete ideas rather than abstract ones, short sentences, just like I'm not doing now, rambling on. So just really, really keeping it simple as much as you can will really help. And that's something that I notice as well, Makaton really helps with. It slows you down because you are trying to think of the signs that you know and using the few signs. It just slows your communication down. It makes it simpler and it's easier to follow. If you can at all, talk to the person, not to the carer. It can be so tempting to turn to the person who can follow quickly, can tell you quickly about something. But it's just, if you went to the doctor and someone kept turning to the person with you rather than asking you how you were, it's not on. It's you know, it's hurtful. They need to be part of their care, and so you speak to the person. Not to say that the carer won't be helpful and that the person might indicate that they want you to ask the carer something because they can give more information, but you know, this is that person's assessment, so that's who you should be speaking to. The other thing that's helpful is asking, because a lot of people I think feel that they don't really know how to speak to someone with an intellectual disability, maybe because they think they haven't done it before. ask. They may have done this a lot more times than you. They may well have been in and out of hospital, in and out of clinics a lot more often than you have, and they'll be able to help you out, and often will. You know, they might have communication aids that they can show you. And yeah, so simple things as well, like yes and no charts. Actually, if things are feeling overwhelming, but someone can point to yes on a piece of paper rather than trying to say it, that can be a lot easier as well. Yeah, just remembering that there is so much of communication that is through body language, through tone, not just through the words you're using. So, you know, make sure that you're using everything available to you to make sure that you're communicating. And also, just because the person isn't communicating with you doesn't mean they're not understanding you. I think that's a really key thing to remember as well. So next slide, please, Lucy. So yeah, and just click twice more if that's okay. All right, we're going to do a super quick recap of these words, okay? And again, yeah, one more click, please, Lucy. Thanks. Again, I'm going to have to trust you're doing it along with me. So, hello, I'm going to look at Lucy and she will adjust it. So, hello. Everyone remember hello? Hello, exactly, very good. Goodbye. Good, and yes. It's a nodding head. Yes, that's right, good. And no, no. So just flat, straight across, no, okay. And good, good. And the opposite of good is bad. That's it, so the opposite finger, bad, yeah? And please and thank you. So do you remember, what did we say? We said tie to the bra, didn't we? That's a long one, thank you. And please, short, yeah, please. Sorry, I've just done it the wrong way around, haven't I? Please to the knees, that's the long one. Thank you is the short one. Tie to the bra, very good. And where? And we are all finished. Okay, that's good. And we'll just skip forward. I think I've got 2 more slides, nothing much to say. There's some links there. I think that this is being recorded, so you can come back and have a look at them. Like I say, a bit of shameless self-promotion, but the interview, for example, is about why I chose intellectual disability psychiatry. Do have a click on them. Someone else has mentioned the prizes and bursaries as well that are there, and there are some student essay prizes. I'd really encourage all of you to get involved with that. And on the next slide, Lucy, I think I've got my contact details. Yeah, so that's me.catl on Twitter. There's the ID Trainees Twitter handle and Psychiatry ID. There's my email address if you would like to get in touch with me, if I can help with anything or answer any questions. I'd be really, really happy to. You can send article ideas or articles themselves to me at that address if you'd like something to submit something for the newsletter. And indeed, I think actually, we've got something that Lucy wrote, which won a prize, which is going to be published in the next newsletter, which will be out very shortly. So there you go. Thanks very much. I think I've rambled on a bit too long, but thanks for listening, and apologies for the technical difficulties at the beginning.
Thank you so much, Dr. Levick. That was really, really inspiring and really interesting, and good to learn a bit of Makason as well. Brilliant. Thank you so much. So last but not least, I would like to introduce Dr. Sam Treymans. If you'd like to share your screen, Dr. Treymans.
Can everyone hear me okay?
Yes. Yeah, we can hear you perfectly.
Cool.
So Dr. Treymans is a clinical lecturer in psychiatry at the University of Leicester, and is an acting consultant in intellectual disability psychiatry. So thank you very much, Dr. Treymans.
Okay. Can everyone see the first slide okay?
Yeah, we can see
Excellent.
that perfectly. Thank you.
Okay. Hi everyone. My name's Sam. I'm an ST6 psychiatrist in intellectual disability psychiatry. I'm currently in a acting up role at Leicester. And I'm also a honorary academic clinical lecturer / PhD student at the University of Leicester. So I'm in the final year of my PhD, as well as the final year of my psychiatry training. So just to start off with, I mean, I know Reggie's already touched upon a lot of the the kind of background to academic psychiatry, but of course we undertake research with regards to mental illness. Most academic psychiatrists also remain clinically active as well, so the vast majority of academically active psychiatrists are also continuing to see patients in a clinical context, which in my opinion is obviously a good thing. Clinicians can help bridge the gap between research and clinical practice. So sometimes there's a risk that there's academics or full-time academics at universities conducting their academic work and full-time clinicians at hospitals conducting their clinical work, and perhaps the links between the two aren't as strong as they should be. So academic clinicians can bridge that gap. Psychiatry of intellectual disabilities, an overlooked, often overlooked, but essential area for research. And indeed, I'd encourage anyone training in psychiatry, but especially in psychiatry of intellectual disability, to consider an academic post as well. And there's not very many of us. So currently, as of November, there's just myself and one other academic intellectual disability psychiatry trainee in the UK, unless there's any others that keep themselves very, very quiet and I just don't know about, but I'm pretty sure there's just two of us. So in terms of academic psychiatry disciplines, these are just some of the different areas of academic psychiatry that you might find yourself interested in or wanting to work in. So you might want to look at drugs and drug response. You might want to have a look at the link between that and genetics, and also neuroimaging is a big area in psychiatric research. Some psychiatrists focus on the talking aspects of therapy, such as more of a kind of psychologically minded research approach. And some, like myself, most of their research revolves around epidemiology. And there's other kind of more social disciplines within academic psychiatry, such as things like health economics, which is of course very important because it's important to know which of our interventions represent value for money. So in terms of the kind of gold guide of the academic career pathway, this is kind of the model pathway that people would follow. So either doing a BSc or MSc either before medical school or intercalating whilst at medical school. And I've just had an excellent intercalated student work on my PhD for their masters, and they've just finished, and I think it was a very rewarding experience for themselves and also for me as well. And then there's foundation training and the academic foundation program, and then the academic clinical fellow program, where people in that role sometimes start to gear up a proposal for an MD or a PhD, that they then might take time out of training between core and higher training to do a MD or a PhD. I would say that MDs are increasingly falling out of favour now. I actually started on an MD myself, and I was recommended by my university to transfer to a PhD, which I subsequently did. I think it's because a lot of people at universities have spoke to me that it's sometimes a bit unclear what an MD is, because depending on where you got your MD in the world, it means different things. So it's a bit ambiguous what it represents to potential employers. In a higher psychiatry training, you might do an academic clinical lecturer post, which might be for a PhD or MD, or it might actually be postdoctoral research training. And then you may look at having a mixed clinical academic career from the end of your training into your consultant life. one of the things I would say is this represents the model route set out by Health Education England, and the majority of people, at least in my experience, don't hold all of these positions along the way, and I can't see any reason why you necessarily have to. I think the important thing is to try and kind of grab the opportunities when they make themselves available to you. So this was my own experience. So I did do an intercalated BSc at med school, and I think that's really good opportunity to at least build some basic research skills. And I kind of dabbled as a clinical fellow during my foundation training, and I didn't do too much research during my core training. I was predominantly focused on passing my membership exams, doing my early psychiatry training, and kind of getting to grips with the craft of psychiatry, I guess. But after I passed my membership exams, I started working on some papers. I didn't take out time between my core and higher training. And during my higher training, I did some research work during my ST4 year, and then towards the end of my ST4 year, I applied for an academic clinical lecturer post. And what that meant was I've worked 50% clinical and academic for my ST5 and ST6 years, and done them over 4 years instead of over 2 years. So that delays when you become a consultant, and in my case it delayed that by 2 years. But I think, to be honest, if you're going to do a PhD during your training, it's probably inevitable that it's going to delay your date of becoming a consultant. For me, that wasn't the biggest thing in the world, but different people have different priorities, so that's always something worth considering. So I'm just going to talk for a few slides about my PhD project. I'm not going to go into exhaustive depth, but just to give you an idea of what I'm doing as an example of a PhD project in academic psychiatry. So the protocol to my study is available online on the BMJ open website for anyone that wants to read further, but it's called the SPRINT study, and we're supported by the National Institute of Health Research. And it's a national study looking at how prevalent autism is among adults admitted to acute mental health wards. So initially, in designing this study, what myself and my supervisor, Professor Brewer, wanted to establish was how much evidence is there out there on how prevalent autism is among people admitted to acute mental health wards. And there wasn't much out there. In fact, we only found 4 eligible papers over the past 30 years. So there really is very limited evidence out there. And of course, within both intellectual disability acute wards and within general adult acute wards, there are several problems associated with undiagnosed autism. So autism may be misdiagnosed as other conditions such as schizophrenia, and then people given therapies that are unlikely to be helpful. The hospital environment might not be adapted to the needs of people of autistic people, and for example, the noise, the overstimulation of light, things like that can be particularly difficult for autistic people. And I mean, one of the things I did for my study is I had an autistic artist do some comic book drawings. So this represents kind of the experience of an autistic patient on an acute mental health ward. So just in summary, like what I was looking at is patients without intellectual disability would go through an initial stage where they would have questionnaire-based testing, and depending on people's scores on the autism questionnaires, that would determine their likelihood of going through for full diagnostic interview. Whereas patients with intellectual disability would immediately proceed for a diagnostic interview. The reason for that is twofold. There's a lack of validated questionnaires in people with intellectual disability. for autism, and autism is much more prevalent in people with intellectual disability. I was also looking at how common co-occurring mental health and physical health conditions were with autistic people. So we're doing it all around the country, and these are our main sites that we're working in, so dotted around the majority of the country. And I am towards the end of my data collection now. I've got a bit of analysis to do, but autism does appear significantly more prevalent among adults admitted to acute mental health wards relative to the general population. And there's a lot of suggestion that there's many patients with undiagnosed autism within this setting, perhaps more commonly within general adult settings compared to intellectual disability settings. That appears to be the trend, but as I said, not all of the data has been analysed. This is kind of an interim halfway through data analysis, whereas at this point I've got about 95% of the data now. And autistic people seem to have heightened rates of co-occurring physical health diagnoses. And of course, the implications, and I think it's really important with any research that you look at what the clinical implications are for your research and how it's going to benefit patients and also potentially carers. So I hope that was useful. I just thought, just as a kind of case example of what an academic psychiatry PhD might constitute, it might be useful for me to touch upon that. But I would want to stress that there's a wide variety of areas of research that one can conduct in academic psychiatry. So genetic work, response to certain medications, more kind of psychological based research. So there's plenty of alternative options, and I think it's about finding something that, one, is something that intellectually stimulates you and that you enjoy, and two, something that is going to benefit patients and is and that you're passionate about. So some of the issues with academic ID psychiatry is that people with intellectual disability have been historically often excluded from research. There's a limited number of academic intellectual disability psychiatrists active within this field relative to other areas, although there does seem to be a trend of more and more people becoming interested and becoming active. There are issues regarding mental capacity and consent. I think this is, I guess, my opinion, and is that sometimes the safeguards put in place for research in people with intellectual disability can be a bit of a double-edged sword, because I think there's a very good reason why they're there, and they're to provide protection for a potentially vulnerable group from potential abuse. But equally, if the safeguards are too stringent, there is a risk that it can make it difficult to do any research in people with intellectual disability. And of course, ultimately, the aim of research is to improve the lives of patients and carers. So it's a difficult balance, really, because it's absolutely a priority to keep people with intellectual disability safe and make sure they don't get exploited. And it's also important that research is conducted that can improve their lives. And I think it's possible to achieve both of those aims. And also, I think there's really a big need to involve patients with intellectual disability and their carers in developing research, and for them to have a prominent part in research studies and to be actively involved. And that's something that I very much tried to do. So I ran patient and public involvement forums in designing my study, and they helped shape the study, and I made several significant changes as a result of those groups. And also I've tried to involve autistic people in other aspects of the study, such as designing artwork for it. But I mean, it's a learning process for me too. So I think we're all on different learning paths in academia as we are in clinical practice. And what I would say is intellectual disability psychiatry is a fascinating area of research where we can help benefit the lives of vulnerable, often overlooked patient group, and I would say it's very rewarding and very interesting. So just some advice would be to identify areas of study that interest you and are relevant to the intellectual disability population. Try and present and try and publish if you can. I think it's particularly difficult as a med student to publish, and I have to say I didn't publish during my undergraduate study. So although it's brilliant if you can, don't feel like research isn't an option for you if you haven't published anything by the time you qualify, because that's not true at all. Also, I think some of us, myself included really, can feel a bit uneasy with self-promotion, but I think in academia you have to promote your work really, because ultimately you need people to read your work and to take notice of your work in order for it to have an impact. So you've kind of got to promote yourself a little bit without so it's, yeah, it's something I've got increasingly used to. Also, I would recommend contacting clinical academics who you'd be interested in working with and being proactive, because as Reggie said earlier, most people are more than happy to be contacted by keen medical students or junior doctors, and it's important to identify role models, so people that, as both clinicians and academics, that you see a lot that you can learn from them, and they're also very selfless and generous with their time. I mean, that was certainly the case for me early in my training with psychiatrists locally, such as the late Professor Bomick and Terry Brewer, who's my PhD supervisor, and also with psychiatrists from further afield, such as Reggie, who was always very generous with his time, and I learned a great deal from. So I think it's really important to try and be proactive and identify people that you can offer something to in terms of working, but also that you can learn something from them. I think Twitter and ResearchGate can be very useful and in staying up to date with research. And I mean, generally speaking, academics will tweet about their research when they publish a paper. So it's sometimes the easiest way to kind of find out something as soon as it's published, because I mean, a lot of people are like me in the sense that they'll tweet it within probably an hour of it being published or something like that. And also, I think it's important to remain patient-centered in all the research you do, and ask yourself how your project's going to help patients and involve patients and carers as much as possible. Although that sounds quite intuitive, I think it's sometimes easy to get lost and to perhaps stray away from that goal. So I think it's sometimes important to remind ourselves. Here's some key links that are available on the Royal College of Psychiatrists website. There is a link to the University of Leicester Clinical Academic Training website, but I'm sure other universities such as Birmingham and Newcastle have equivalent programs running and equivalent websites. Also, with a few colleagues, we published a chapter in the Oxford textbook of Psychiatry of Intellectual Disability that was edited by Reggie and Professor Bomick, and on the current and future research priorities in our field. So thank you very much. I mean, I appreciate we're running a bit late, but I mean, if there's any questions, or indeed if anyone wants to contact me either on Twitter or via my university email, then I'm more than happy to speak to any of you, and thank you very much for your time.
Brilliant, thank you so much. That was really interesting and such really useful advice as well. And it was really interesting to hear about your PhD project as well.
Thanks, Lucy. Am I still sharing my presentation screen?
No, you
okay,
stop sharing that now.
Excellent. I was just double checking that I'd stopped sharing, but thank you.
Oh, brilliant, thank you. So I think Bratney was going to like kind of lead the questions now.
Yes, so once again, a massive thank you to all of our speakers, hearing from all different sides of ID, from the actual patient experience to what it's like in training, to what it's like being a consultant, medical leadership, all of these different things really show the wealth of what ID has to offer. But now kind of back to you guys, do you have any questions for any of our panel? Feel free to pop them in the chat or just kind of unmute yourself if you want. But in the meantime, I have a question for Professor Roy. So you mentioned about kind of the whole STOMP agenda. How has COVID impacted the STOMP agenda and kind of prescription of psychotropic drugs amongst people with ID?
There is some evidence to suggest that the consequences of COVID has been a increased difficulty in people being able to access face-to-face interventions, and that are mainly psychosocial interventions, low-level support, etc. So I think there has been a tendency to swing towards the use of anxiolytics and antipsychotic drugs. So I think that there may have been an increased use of these things over the last few months. So yeah, I hope that as people get more conversant with remote technology, then they'll be able to resume some level of face-to-face contact.
Okay, a question for Elliot.
Yes.
What advice do you think is most important for medical students to know when it comes to interacting with people who have autism spectrum disorders?
Listen. I mean, that's fairly broad advice, but I think it's very important to listen to them because they're going to have experiences that you may not be aware of and that you may not understand. And I think it's important to meet them on their level rather than try to apply sort of, because you might have some sort of understanding of an idea of the way things are and the way things are taught and the way things are applied in medicine, but that sort of one size fits all hasn't necessarily worked for me with some therapy in the past. So I think it's important to try and like meet them where their head is coming from and be patient as well. I think it's important, and you know, the general stuff as well, like and I mean, I suppose as well, I'd say, at least for me, and I think this applies to others as well, make sure you explain things properly and do what you can to like disarm any nervousness, because I know I feel nervous when I go into appointments and such. So yeah, I guess those are my top three.
Yeah, so we have a question from Charlotte, who's a first-year medical student. She knows that a lot of the essays for clinical years only, and likewise with research opportunities. I don't think it'd be very helpful to anyone, but is there anything that a first year can do to develop their skills in CV? So I think this Dr. Tromans could be a good person to answer this one.
Yes, can people hear me? Yeah. I mean, I think when you're at medical school, of course, understandably, I mean, the priority is to get through medical school and to make sure that you meet the requirements of your medical school course. But I think it is possible to publish whilst on the medical school course, even at an early stage. I mean, I've recently published a paper with a student that's just started their third year. I mean, what I would probably say, if I can offer any advice, especially that early on, is to look at contacting people who are working in areas of research that you're interested in. And also another recommendation I would have, that based upon my own experience and the own mistakes that I made earlier on in my training, is early on, try not to publish something like incredibly ambitious, because you're just starting out, and there is absolutely nothing wrong with publishing a case report or a case series or a good quality audit or a simple study, and it will very much give you the chance to learn like writing skills for writing for publication, presenting your findings. Whereas the risk if you start trying to do something incredibly ambitious whilst on the medical courses, you're just starting out in research. You've got the demands of the medical degree as well. So by the time such an ambitious study probably comes to publication or fruition, you might be long forgotten because it might be several years afterwards. So I think it's probably best to start off with modest projects and building those relationships with people who you consider clinical role models.
Would it be all right to add something, I suppose, more from, I guess, the clinical side of things? Obviously, Sam was speaking a lot about the research side because that's where his specialty lies. But I know from the point of view of thinking of coming to interviews for entering intellectual disability training, some of what they're looking for is your commitment to the specialty. And
oh, I think you're frozen. Is anyone else having Dr. Levick's being frozen?
Yeah.
Okay.
I'll probably fill in there. Charlotte, if you want to write something in your first year, write book reviews. Select 2 or 3 popular books, which, if you're interested in developmental disorders, which have people with developmental disorders as their central characters, or refer to them. Write reviews, limited to 300 to 500 words, submit to a number of journals. There is a market for book reviews, and if you publish in a fairly referenced journal, that will help you, because in first and second year, in your preclinical years, it is probably a little bit too ambitious to think of case reports and case series and so on. But you can establish and demonstrate your interest fairly well in advance. Sam would know this. There are examples of medical students who have written about characters in popular fiction with autism, and how women with autism are underrepresented in popular fiction. And so on, so this is, if you have an interest in reading, that would be one way to go about, and a fairly quick win, really, and it shouldn't interfere too much with your medical school exams either.
And may I also offer a suggestion that one of my earliest publications was actually a letter about something I felt strongly about, or an article I had read. I think sometimes that's a quick way to see your name in print. That's quite heartening, actually.
My apologies.
Dr. Levick's back. So
yeah, I'm afraid I'm not quite sure when it cut out there. Technology is not being my friend today. I was saying that volunteering with a group would be very useful. I know other people who during medical school have done jobs to supplement their income, and some people who have worked as support workers, for example. And again, you can go and work as a support worker with this patient group, and it would give you a really good experience of actually what their day-to-day needs are, what skills you can learn from them, and all of this really shows that kind of commitment to specialty and interest in the patient group. So that there's a lot of things that you can do as well. Although I do like that last suggestion. A letter about something you feel strongly about is a really good and quick way in as well. Thanks for bearing with me.
Just to kind of like add to that from a student perspective. So I got involved in ID research relatively early on in my third year. And the way that I did that was I simply sent emails. I just sent loads of emails around to loads of different ID consultants in the Northeast, being like, I'm really interested, I'm quite curious. Will you take me on for some research? And I think going at it from a kind of curiosity perspective as opposed to ticking points for your CV for applications later on. That's much more useful in the long run, because you're going at it with a view of trying to solve problems, as opposed to with a view of getting an extra point for your foundation application. So having that kind of sense of actual genuine curiosity about wanting to make a difference, that's really helpful. And consultants will love that, genuinely.
Yeah, we had special study modules that we could choose as well during med school when I was there, and that is something that you could do. But even actually beyond that, just on your rotations, if there is a particular patient that interests you, go for that patient, go and spend a bit of more time with them, and like everyone has said, speak to the more senior doctors around, ask them questions. They'll be more than happy to fill you in, and all of that stuff will give you more information, things that you can talk about in interview. Just more stuff to follow your interest.
The one thing I would add about that, about what you said, Ratnu, about point scoring for interviews, is I think sometimes it's tempting to get too hung up on that. But I think if you're showing an interest in something that genuinely interests you and you're enthusiastic, the points will come. So I think the important thing is to just, if you're interested in intellectual disability psychiatry, or anything else for that matter, I think just by being passionate and motivated to do something you care about, the points will sort themselves out. So you really don't need to worry too much about that.
Okay, I think Lucy had a question.
So I was wondering, so thank you very much for all of your answers and contributions so far in this Q&A. So I wanted to ask about some of the kind of healthcare inequalities that are experienced by people with with intellectual disabilities. I was wondering about what kind of you feel is like the main is kind of how is how like these equalities can be addressed, and what kind of main priorities are.
It's funny you should mention that. That is a topic of a webinar I went to today, run by the Department of Health in England, about the shocking increase in the death rate of people with learning disabilities over the last few months. And a lot of it is just basically, seems to me, and it seems to them also, based on a lack of recognition, lack of doing very simple things, lack of taking changes in people's functioning seriously, not understanding the difficulties people have, the reluctance people have to engage with healthcare. So if you look at a journey from the beginning of the change to the end, there are lots of obstacles which we systematically overlook, and that has led to the. And I think it's up to us in a way to champion these issues and to bring it to the light of mainstream healthcare. Not to be nihilistic about people with learning disability just because they have a learning disability. This has been shown to have happened in the early part of the pandemic, actually. So yeah, there's a lot. It's a very, very worrying tendency which we have to try and reverse.
Thank you very much.
So to kind of add to that, what can we as kind of future doctors do to become more effective advocates for people with intellectual disabilities?
I think some of it was covered by Elliot, to listen. I think if you start listening, not just hearing, then I think you start understanding but at the end of the day, if you ever had a temporary disability due to a broken arm or a leg, you don't fundamentally become a broken arm or a leg. You become a person with a temporary problem, and you want to basically get back to normal. So I think you regard people as just like yourself, really, with the same ambitions and the same hopes and fears. Then one can start becoming more interested in what obstacles they are facing, And I think this is about making sense of people. I think a combination of things that we said, but we have a big role in championing their cause at the moment. All people working in learning disability services have got to stand up and advocate for people who are not able to express their ill health, and who have chronically been sidelined and ignored, and they will be expecting that to happen again, even when they're not feeling well.
Thank you for that.
Yeah, I would just add, I suppose we've spoken a bit about it, haven't we, about like diagnostic overshadowing. So I think it's really just keeping one's mind broad about what could be going on here, and really being curious about what it is that the patient is telling you, what their behavior is telling you. You know, make sure that you haven't forgotten that there might be a physical health issue going on that they're not able to explain. And if it's not a physical health issue, you know, go through everything as you would with any patient. But I suppose, like I say, just keeping that curiosity, because actually there are some things that they might not be able to express. So you need to keep that curiosity on behalf of the patient. And yeah, I think also something Dr. Roy mentioned was advocating for your patients, because I've come across, sadly to say, I'm afraid, I have come across people who, for example, were not given screening because they were unable to tolerate coming to the GP surgery, and they didn't make reasonable adjustments to do that screening in another way. I've come across patients who should have had a surgery, but they felt that this person wouldn't be able to tolerate the sort of the follow-up to the surgery and the kind of things that they would need to do to keep themselves safe, and didn't, you know, discounted the fact that they have carers who will help look after them, and again making reasonable adjustments to say that that patient can access the same thing as anyone can. You know, and in the same way as I guess if you had a patient who didn't speak English, you wouldn't just say, well, they can't understand it. You'd get an interpreter for them. So you make an adjustment for the thing that is preventing them being able to access what they should be able to access. And that's something that people don't always think of. Sometimes, you know, it's not always due to prejudice. Unfortunately, sometimes it still is, but it's not always due to prejudice. Sometimes it's because someone doesn't know what is available. And that's where we can come in and say, actually, there's something we can do about that. So being an advocate for your patients.
If I can just add something to that is quite an important point. It is not always because of prejudice. It is important to advocate without being seen to be virtue signaling or saying I am ethical and all of you are unethical. That is not true at all. And there is the sort of slightly statistics nerd in me saying, even before COVID, when you think of excess mortality in people with learning disability, 40% of that mortality was because of respiratory causes. This is even before COVID hit us. So the focus really ought to be on basic primary care and the importance of things as simple as annual health checks. But that needs to be implemented without blaming fellow professionals of being uncaring when there is this special group of intellectual disability specialists who have a superior grade of empathy, you see. And that is really, really crucial. So something as basic as annual health checks, advocating for that, facilitating that would help improve the baseline. Because in that excess mortality, and studies will come out in the next 6 months or so, in that excess mortality, the amount that can be even indirectly attributed to prejudice or deliberate negligence would be quite small. It is going to be a sort of cumulative process where basic things were missed out right at the beginning. So, and that will equally apply to anyone with other medical complications. So if you have a pre-existing medical condition, you are likely to come out worse off in the pandemic. And our people almost have a double or triple jeopardy in that. But I think that is quite an important point that Kathleen made.
I think if I could follow on from from something Dr. Alexander said. I think while it's important not to come off as if you're the like you're so confident that you're the moral high ground, I think from another perspective, at least my perspective, it's important to be able to tell someone when there is something they can improve on. I suppose as an equal or as a friend or as a co-worker or an associate. And when it is a bit more malicious, it's important to be able to call someone out when they are lacking in that regard. So there's the sort of balance. You don't want to come off like you're, I suppose preachy would be the word, but you've still got to make your point. And sometimes I think you've got to make that point firmly.
Do you know, Elliot, I came across such a good example of that recently, where there was a discussion where there was someone who was describing an extreme food aversion, and their family said that they will starve if they don't have this certain thing provided for. And a lot of people were like, oh, well, that's just ridiculous, that's pandering, and didn't understand actually the extreme sensory sensitivities that can go with an autism diagnosis sometimes. And it was lack of knowledge. And it came across as malicious, and it needed to be called out. You're absolutely right. And actually what it was that they just didn't understand that this can be a problem sometimes. And so with the right information, they were able to make that adjustment and realize that that adjustment is a very necessary one to make for this particular patient. You know, I agree with you, we have to call it out. And also sometimes it's due to lack of knowledge, unfortunately.
Yeah, I would agree with that. Thank you.
I mean, I guess one thing that I thought to say as well is that I mean, sometimes there's emphasis on treating people with intellectual disability equally, but treating them equally isn't always what's actually the fairest strategy. So, for example, GPs typically have appointments of 7 to 8 minutes or 10 minutes. That might not be reasonable for somebody with intellectual disability. They may legitimately need more time. So I think rather than equality, it's about equity, and it's about ensuring that people with intellectual disabilities receive equitable treatment relative to their needs. But having said that, I mean, I would echo the sentiments of Reggie in the sense that, in my experience as well, the vast majority of healthcare professionals are well-meaning and genuinely want what's best for all of their patients. And I think it's important to get our message across without coming across as preachy or superior. Because we're not. We're all doctors. We're all trying to do the best for our patients. In large regard, I mean, I appreciate that some stigmatization does go on and some discrimination does go on, and of course that needs to be called out as Elliot suggested. But I think a lot of the time it's about educating or sharing knowledge without coming across as preaching.
I think I would add, sometimes you've got to analyze yourself as well. You can't act like you're the perfect repository of knowledge. There may be a bias or a stigma that you continue to hold on to that you need to analyze and unpick. And that's just sort of how society works. We get ingrained with these things when we're young, but we need to, like, it's important not to hold anybody up on a pedestal, but it's important not to hold yourself up on a pedestal and think that you're going to get it all perfect. You might encounter something where your first judgment is not the fairest one or the correct one, and you need to work through realizing why that is, and then thinking, okay, well, this is what's better, this is what's healthier, this is what's fairer or safer to believe for people, and then go from there, really.
Absolutely. No, absolutely. I agree. I mean, I can certainly say for myself, there's a vast amount that I've learnt from other healthcare professionals, and equally there's a vast amount I've learnt from patients and carers. But I think, I mean, I'm relatively early on in my career, but I think even for people towards the end of their career, it's an ongoing learning process. And I agree. I think you're absolutely right, Elliot, in that none of us should kind of get into the mentality that we've made it and we know more than know more than our peers.
Yeah, thank you. Yeah.
Great, these are really, really valuable insights. I think we'll call it there for the questions. Just one final one to Elliot. What was the font?
Yeah, the font. I'm glad you asked. It's from a video game that came out in 2017 called Doki Doki Literature Club,
Okay.
which you may be familiar with. It's the font used for the handwriting of a girl called Sayori who wears the red bow. So I should warn before anyone goes and looks up that game. It starts out being, it looks like a cutesy dating sim, and then very suddenly it flips and becomes a psychological horror game. Like, it does some strange things, and I relate to that character Sayori from the game, so I thought I'd use that font as a bit of fun. But if anyone does want to go and look up the game, bear in mind that, like, general content warning, there's a lot of dark things that will turn up in it, so just be aware of that if you decide to look it up.
Wow, and what a note to end on psychological horror and dating sims. But no, well, thank you very much to everyone who's come along this evening. I hope you found it as inspiring as Lucy and I have. We were just messaging like, oh my God, this is so good. This is so good. Can't believe all this amazing stuff they're saying. So yeah, I mean, thank you all once again. Thank you to all our speakers. If the speakers can hang behind for about 5-10 minutes afterwards for a quick debrief, that's great.
If it's all right, I've put my Twitter in the chat if anyone wants to follow me there. So thank you.
Great. But otherwise, thank you all for staying till 9, and have a wonderful evening and enjoy the rest of lockdown too. Thank you all very much.
Thank you. Thank you, everybody.
Thank you very much, everyone.